Ladies and gentlemen, good morning. My name is Tomaž Kocjan. I'm a consultant endocrinologist at University Medical Center Ljubljana and also a professor of internal medicine and endocrinology at Medical Faculty University of Ljubljana. Thank you very much for the invitation. Here is my disclosure, and I will talk about our experience in treatment of Cushing syndrome. So, is this really the Slovenian experience? It is not entirely, because some patients are also managed at University Clinical Center Maribor, but most patients from our tiny country, of population of 2 million, are managed at our institution, University Medical Center Ljubljana. As we heard before, Cushing syndrome means a significantly increased risk for several important comorbidities and clinical complications, which brings, of course, excessive mortality for these patients. But it's not only a difficult disease for the patient, it is also very difficult for us, for their physicians, as we heard before. So I will provide you with some epidemiological data, or more frankly speaking, about few numbers of our patients. Then we will review some newer approaches to diagnostics and treatment via 2 clinical cases. So a population of 2 million, this means that our population of Cushing syndrome patients is quite small. As you can see, 56 patients in the last 5 years. So most of them, of course, Cushing's disease, as shown here. And this was a little bit less than in the previous 5 years, probably due to the COVID-19 epidemics. So let's move to the Cushing's disease. So we, of course, start with the pituitary surgery. And we have a dedicated multidisciplinary board for pituitary tumors at our hospital. This is a very good acquisition, actually, consisting at least of a neurosurgeon, neuroradiologist, and endocrinologist. We are very lucky that we have a very good dedicated pituitary surgeon, Professor Bošnjak. You can see one of his cases of a macroadenoma pituitary patient. On the left side before the operation, and on the right side after the operation, when this huge tumor was completely resected. We also do some operations with indocyanine green dye, enabling us to better recognize the tumor and pituitary tissue. Namely, pituitary has a better vasculature than the tumor, and you can see that it is greener than the tumor tissue. We published our results about a small prospective study using this method recently. Of course, most patients with Cushing's disease have microadenomas. The average size of the tumors in the last 5 years was 9 millimeters. Ranging from invisible, so 0 millimeters, to 24 millimeters. What is the short-term cure rate after transperineal surgery? So it was about 80%, as you can see here, and it was similar in the previous 5 years. So a lot of patients are at least cured in the short term by surgery. What to do after recurrence with persistent disease? So mostly we decide for a second surgery or even third surgery, even knowing that this means, of course, worse results. Still some patients, so small population, good surgeon, means that we have quite few candidates for medical treatment. And at the moment there are 4 patients on pasireotide, 1 in combination with cabergoline, and 1 patient on oscillodrostat in our population of Cushing's disease patients. How about ectopic Cushing syndrome? 5 of them were treated at our institution during this period. 1 patient was actually metastatic from the beginning, and this patient died quite soon after the diagnosis during treatment with oscillodrostat. Other 4 patients were operated on. 1 had successfully resected net in the appendix, and 3 other patients had bronchial carcinoid tumors. How about finding these tumors? We rely on molecular diagnostics a lot. So here is the gallium dotatate PET-CT of the last patient with the ectopic Cushing's. You might see the primary tumor in the pulmonary window, but probably it is better visible liver metastasis, which is even better visualized here. And this patient is now being treated with oscillodrostat to control his or their hypercortisolism. How about ACTH-independent Cushing syndrome? We do have also a multidisciplinary board for adrenal tumors, usually every week, meeting at least urologist, radiologist, and endocrinologist. And we do also have a multidisciplinary board for ACC patients at our neighboring institution of Institute of Oncology. And you can see the modalities of treatment, so mainly surgery, and also, of course, mitotain for selected patients with ACC, metyrapon, and other modalities. So let's move to our first clinical case. This was a recent female patient who was referred to us due to oligomenorrhea, and the referral diagnosis was PCOS because her gynecologist found PCO morphology on vaginal ultrasound. But this patient also complained of easy bruising, and of course this meant that her diagnostics went also into the direction of Cushing's. So here is the basic hormonal picture. You can see that this could also go along with PCOS, with high anti-Mullerian hormone and high androgens. But of course, overnight dexamethasone suppression test was positive, and so it was low-dose dexamethasone suppression test, urinary free cortisol, also midnight salivary cortisol, and ACTH was high, so this means this was an HCTH-dependent Cushing syndrome. Of course, the next step was the pituitary MRI, and you might see on T1 weighted image hyperintensive spot, so this might be a small rhabdosis, so this was the opinion of the neuroradiologist. Also, the size was approximately 4 millimeters, so we proceeded to IPSS. So this is in Slovenian, taken directly from our discharge letter, but you can probably realize the right catheter on the left. In the middle there is left catheter, and on the right of the slide is the periphery. We do IPSS with prolactin to control for selectivity, and you can see that the selective catheterization was achieved on the right side, and there was a very nice gradient right to periphery, also in basal and after stimulation conditions. And of course, we use desmopressin because there is no CRH. So this was clearly pointing to the Cushing's disease. However, you know that surgeons sometimes want to have something more reliable, so they want to have some imaging. And it was also shown in this retrospective study on about 130 Cushing's disease patients that clearly positive imaging was associated with 18 times greater odds of finding microadenoma in surgery, and with more than 4 times greater odds of immediate post-surgical biochemical remission. So what to do in this situation? We can use molecular imaging once again. So you know that we have a lot of new molecular imaging based on amino acids. So one of these approaches is 11C methionine PET MRI. So you need, due to very short half-life of 11C of 20 minutes, you need a cyclotron at your hospital. This is unfortunately not the case in Ljubljana. So we send these patients abroad. So for instance, this is another patient. You can see on the MRI a possible regrowth of a pituitary tumor. And of course, this regrowth was very nicely imaged with this so-called PET MRI. But recently, we have introduced a new method. So this is so-called 18-fluorine fluoroethyl L-tyrosine PET-CT, or so-called FET-PET-CT, which uses, as you can see, 18-fluorine. So this means that it is accessible also to hospitals without cyclotron. And we use this method on this patient, and you can clearly see, especially on the sagittal cut, so this is on the right-hand side, you can see the sella, and you can clearly see in green color the tumor. So now the surgeon was satisfied, and the patient was sent to surgery. You can now see the tumor. It was about 3 to 4 millimeters in size. And this operation was successful. So the patient entered the complete remission. And also the histopathological result was as expected. So it was a corticotroph ACTH plus a densely granulated adenoma with a little bit higher Ki-67 than desired for. So let's move to the second case. So this is about several treatment possibilities in Cushing's disease patients. So this is an older case of mine. So this patient presented in 2011. He actually presented to our colleagues at cardiology with paroxysmal atrial fibrillation. And they actually realized that this patient might have Cushing's. And this was, of course, proven, and I do not have the initial images, but you have to believe me that this patient had intra and supracellular pituitary macroadenoma, 16.12 millimeters. And of course, this was once again Cushing's disease. This patient was put on metarapon, on block and replace regimen while awaiting surgery, and he was also started on zoledronic acid due to his glucocorticoid-induced osteoporosis with fractured T8 vertebra. So then he had his operation in September, so after holidays, and here are his post-operative cortisol values. So this was not a clear remission, at least according to the new consensus, but you can see that his basal cortisol was much lower than before. Also ACTH normalized, and also histopathology was also concordant with an ACTH adenoma. I would like to point out the very high Ki-67 of 14.5%. So still after 3 to 6 months, when we do all these follow-up tests in our pituitary patients, you can see that his short synactin test was still not optimal, so he was still insufficient, and he was considered cured. However, during September of the same year, so 2012, he started to notice once again signs and symptoms of Cushing's syndrome. And this was, of course, proved also biochemically. I can show you the pituitary MRI. You can probably notice the paracellular remnant or recidivant growth of the tumor marked with the arrow. And of course, this patient was once again put on metarapon and then operated 2 times actually. So the first time in March and the second time in November of 2013. And you can see that once again, there was some success. So they actually got the pituitary adenoma tissue with even higher Ki-67 of 16.3%. Then, of course, this was not entirely successful. The patient was not cured. At that time, we had pasireotide, short-term pasireotide, as a compassionate use, and he was started on pasireotide, 600 micrograms 2 times a day, then increased to 900 micrograms 2 times a day, and of course, we started him on metformin and DPP-4 inhibitor due to worsening of his hyperglycemia. What happened next? He was not controlled with pasireotide. We added cabergoline, and then we also added metyrapone to his treatment, so he was on triple therapy. Why this triple therapy? Because a few years ago, they showed in Netherlands that triple therapy using pasireotide, cabergoline, and ketoconazole might be successful in severe Cushing's disease. So we did not have ketoconazole, so we used metyrapone. What next? So we felt that this patient needs some radiotherapy because of his very aggressive behavior, and he received some fractionated radiotherapy in total of 45 grays. He entered remission. However, after 2 years, recurrent disease occurred. So once again, he was then started on pasireotide and metyrapone. And in March 2017, he was sent to Brussels to have his MET-PET MRI, as it was shown before. And they clearly showed this right paracellular tumor remnant was active. You can also see it on the MRI. This patient was then treated with gamma knife in Brussels, and he entered quite short-lived remission. So the question is this tumor an aggressive pituitary tumor or not? Let us have a look at a recent review paper about aggressive pituitary tumors. You can see the proposed criteria for this diagnosis, and we can see that this patient had a cortitroph invasive macroadenoma. He was a male. He also had very rapid relapse and progression after surgical removal, also progressed after radiotherapy, and also had very high proliferation markers. So this was definitely an aggressive pituitary tumor. And as a matter of fact, among aggressive pituitary tumors, the ACTH secreting subtype, as you can see on the upper graph, are overrepresented. So this was quite expected in this case. So what next with this patient? Once again, recurrent Cushing's disease in August 2018. Then he was put on pasireotide, long-acting release, 10 milligrams, 30 milligrams, 40 milligrams, and then metyrapone was also added. Then he developed adrenal insufficiency, so metyrapone was discontinued and hydrocortisone was added. However, still the tumor was growing even on pasireotide. And you can see on the MRIs, it is marked by an arrow that this tumor on the right paracellular position was now in contact with his right oculomotor nerve, and he started to experience some dual vision, so what was very annoying. So what to do with this patient? Then we thought we could try peptide receptor radionuclide therapy. So you're probably aware of this therapy. This is quite extensively used for gastrointestinal NET patients at our institution. It uses the concept that these tumors actually have somatostatin receptors, and you can then bind usually 177 lutetium to a somatostatin analog, and then to use this for internal radiation to destroy the tumor. As a matter of fact, we had some experience with a pituitary tumor and with this therapy before. So this is one of my other patients with very aggressive acromegaly. You can see the huge tumor remnant. You have first to do the somatostatin receptor PET-CT to show if there is any accumulation of if there are any receptors in the pituitary tumor, and usually, as I was instructed by our colleagues from nuclear medicine, you should have at least similar accumulation as in the liver. And you can see that in this patient, this was actually the case, and he was successfully treated with 177 lutetium. And this is the PET scan with lutetium after giving him lutetium. However, in our patient, this was unfortunately not the case. So you can see that there were no accumulations, so the density of somatostatin receptors in his pituitary tumor remnant was too low to try this therapy. And then we, of course, checked the guidelines once again. And, of course, these guidelines issued in 2018 recommend temozolomide as first-line chemotherapy for aggressive pituitary tumors and pituitary carcinomas following documented tumor growth. You can see some published series, some smaller series, but with very variable effect of temozolomide in these patients. Still, there were some very successful reports of this treatment. And what actually is temozolomide? So temozolomide is an alkylating agent. It was started like 150 milligrams for 5 consecutive days every 28 days, and then increased to 200 milligrams. This drug enters the cell and then methylates DNA and interrupts the cell repair mechanisms, and this, of course, should cause the tumor cell apoptosis. This patient was quite successfully treated from May 2021 to May 2022 with temozolomide. This drug was quite well, very well tolerated, but after 1 year of treatment, there was continuous growth of the tumor, so this was then considered unsuccessful and temozolomide was stopped. So what to give after failed temozolomide? So there are several possibilities listed, for instance, in this reference here. So you can see that the series are quite small, so you can try peptide receptor treatment as shown before. You can try bevacizumab, or you can try immunotherapy. All these therapies have very variable effects. You can see, so complete response, partial response, stagnant disease, and progression. So we discussed this case with our oncologists, and they actually felt that immunotherapy would have more adverse events than bevacizumab. So this patient was then started on bevacizumab in June 2023, so still on pasireotide. So this patient is continuously on pasireotide. So 10 milligrams per kilo every 4 weeks. What is bevacizumab? Bevacizumab is a monoclonal antibody against vascular endothelial growth factor, and it inhibits angiogenesis of the tumor. And what happened next? So after 3 courses of bevacizumab, this tumor was completely avascular, so it underwent necrosis, and this tumor is stable ever since. So hopefully, I would need to knock on wood, but hopefully this therapeutic option will be successful also in the future. So to conclude, Cushing syndrome is a terrible disease, not only for patients, but also for doctors. And our patients need highly individualized diagnostics, therapy, not only surgical, but also medical. And this is only possible in the setting of multidisciplinary teams. And I would like to acknowledge some of our colleagues who are involved in treatment of our Cushing's patients. Thank you very much for your attention.